Welcome to RAAONLINE. So today we have a very important topic, the pediatric trauma. So the basic understanding is a small child, the pediatric population, the children, they are not small adult. Okay, the drug which you give for an adult of 18 years or 19 years old, it's not the same what you give for the pediatric population, right? It's not like 50% of the drug, right? So a pediatric population is not a small adult. Okay, they have significant difference anatomically, physiologically. So the treatment also varies, having understood this kind of anatomical and physiological variations. Okay, so pediatric trauma. First, we'll start from the airway, breathing and circulation. This is a very important exam question for you, right? In what way a pediatric airway is different from an adult? So smaller the child, greater the disproportion between the size of cranium and the midface. Okay. Moreover, not only the cranium, even the occiput is also very large. So this large occiput causes passive flexion of the cervical spine so that the posterior pharynx buckles anteriorly. Okay. So can you look at this? So this is the occiput, right? Since there's a huge occiput, there is passive flexion at the cervical level. So when it passively flexes at the cervical level, this posterior pharynx, this part, buckles anteriorly. Okay, so to avoid this kind of passive flexion of the cervical spine, the plane of midface is maintained parallel to the spine board. Can you see that? This is the plane here, right? This is the plane and this is the plane of the board. See, they are not in alignment, right? So you need to do any maneuver so that you can bring the plane of the midface and the plane of the stature or the board with equalcy. Okay, so placement of 1-inch layer of padding beneath the infant or toddler's entire torso is done. Okay, this is the image which I was speaking about. Okay, so see this is a plane of the midface. This is plane of the table, right? Because the occiput is very large, there is passive flexion at the level of cervical spine. Okay, the posterior pharynx is actually buckles anteriorly. Okay, so the plane of the midface is not parallel with the plane of the table. So what you need to do, you take a 1 inch of a cloth and place it from the shoulders, okay, to the entire body, so that the plane of this particular midface comes parallel with the plane of the table. Okay, so this passive flexion can be avoided, right? The soft tissues of the infant's oropharynx, let it be the tongue or a tonsil, all these things are large, especially when you are trying to intubate the child. A large tongue can obscure your view. Okay, a large tonsil can obscure your view. Moreover, any nasopharyngeal airway, oropharyngeal airway, or even a Ryle's tube can get complicated because these soft tissues are extremely fragile and they can start bleeding. Okay, so any bleed in this kind of situation can worsen the aspiration, can worsen your airway. Okay, larynx is funnel shaped, so secretions accumulate in the retropharyngeal space, right? The larynx and vocal cords are more cephalad or anterior in the neck. So when you try to intubate, you will not be able to see the larynx or the vocal cord that easily as compared to an adult population, right? Moreover, the infant trachea is approximately 5 cm long. It grows maximum up to 7 or 8 cm by 18 months. Okay, so if we don't understand this particular length, we might even induce a single bronchus intubation. Okay, so failure to appreciate this short length can result in intubation of the right mainstem bronchus, inadequate ventilation, accidental tube dislodgement, or mechanical barotrauma. So we need to know the optimal ETT depth, how much we should secure. Okay, so the optimal endotracheal tube depth can be calculated as 3 times the appropriate tube size. Okay, for example, if you are using a tube of 4.0, then the position should be 4 into 3 is 12 centimeter from the gums. Okay, this is where you need to roughly secure, but clinically you need to assess whether that's a correct position. Okay, so management in a spontaneously breathing child with a partially obstructed airway, optimize the airway by keeping the plane of the face parallel to the plane of the stature or restricting the cervical spine motion. Okay, use a jaw thrust maneuver combined with bimanual inline stabilization and open the airway. Okay, once you open the mouth, clear the secretion, debris and administer oxygen. Okay, so whenever a question is asked about an airway, do not jump and tell about intubation. Okay, so the moment you say intubation, you might fail, right? There are proper steps you need to undergo, only then you can take steps for intubation. Okay, so first thing is you need to optimize the airway and manual inline stabilization should be all round, and use of jaw thrust maneuvers along with your bimanual inline stabilization. Open the airway, clear the secretions debris, administer oxygen. So these are the initial steps you need to perform. Okay, don't jump to intubation.